one of the key advantages of this technology over other methods of verifying graft patency, which usually use ultrasound, is that if this will actually give you an anatomic description of where the problem is, if there is a problem with the graft. And if the graft is kinked, it will show you precisely where the kink is. If there is a problem at your distal anastomosis, you'll see where the problem is.
The technology is very, very user-friendly. You can bring it into the operating room. It's not bulky. You don't have to protect the operating room staff from conventional radiation. So it's user-friendly intraoperatively, but also you get real-time feedback on the result. And that is one of the strongest ways to improve outcomes immediately, because you're able to get immediate feedback.
SPY technology imaging is very helpful to us in many ways in imaging the vessels after they have been bypassed to show patency and flow.
The technique of imaging really depends on a number of things. It depends on how many bypasses you're doing, the type of conduits you use, whether or not you're using arterial grafts or vein grafts, and whether or not the revascularization procedure you're doing is either on pump or off pump.
The single most important part of the information from the SPY Novadac technology is to check that the grafts are patent, and as I've said, particularly the internal mammary artery to the front wall of the heart. But in reality, it's not only useful for the surgeon to know that, it can be useful for the patient to see images, and for the cardiologist who referred the patient for the operation to see that there's documented evidence of graft patency.
The availability and development of intraoperative imaging is of incredible importance in determining how well we have performed these anastomoses, and hopefully to minimize the chance of recurrent narrowing or restenosis down the road.
In terms of speaking to my colleagues who may be thinking of using the SPY Novadac camera system for imaging grafts, my advice to them would be the only reason now that a patient is even referred for coronary artery bypass grafting is to get a mammary artery to the left anterior descending coronary artery, because that is the graft that is proven to affect the patient's long-term survival. That's the thing that will guarantee additional survival. So if in the operating room you do nothing else except check that the patient is leaving your OR with a patent mammary graft, you have changed that patient's long-term survival prospects.